Well, good afternoon, and welcome to Ask the Docs, a Fertility Institute of Hawaii live stream. This month, our topic is Reflections on National Infertility Awareness Week, which was last week, April 18th through the 24th. I am Dr. John Fraterelli, and I'm here with Dr. Anat Carmon and Dr. Emily Goulet. Thank you for joining us today. We have a lot of good information to share with you. And also, I thank everyone for submitting questions previously. We will be addressing those at the end of our live stream today, so please stay tuned. The topics we're going to discuss today, and hopefully in this order, will be what is infertility, how many people does it affect, what are the symptoms of infertility, when should someone seek help. We'll also discuss that it's a male and female problem. We'll discuss what's the evaluation process, what are the common treatments, and then discuss some of the newer treatments. And then obviously answer any questions that you have. So again, welcome. And I'll start off by throwing the question out there. What is infertility?
So infertility is defined as the difficulty in achieving pregnancy. And that usually is defined as attempting to conceive for approximately 1 year, or if you're over the age of 35 or 35 years old, then potentially after 6 months. I think that the question also becomes how many people does this affect, but also when to actually seek the care of a specialist. And so when you're trying to conceive and having trouble, even if it's been kind of less than a year or less than 6 months, if you have known issues that are associated with infertility, you may seek the advice of a specialist sooner.
And if I can, I'd like to add on to that a little bit. Infertility is not just, while it includes those things, we can broaden it to also include those who may be getting pregnant, but may not be able to make it all the way to term. And so if you're having miscarriages or recurrent miscarriages, that's also a reason to seek out a specialist to see if there's anything that can be done to prevent another miscarriage from happening again.
And I think it's also important to realize that most people don't have infertility. Most people have subfertility, meaning that, if you keep trying for another 2 years, there's, 50% of people that come see us will get pregnant. But the reality is after you've been trying for 6 months or a year or however long you've been trying, to tell somebody to go try for another 2 years because, half the time you'll get pregnant is unrealistic, when a lot of times it's a matter of simple treatments that we have, which we'll get into as well. One question I would have that patients do ask a lot, why is there a difference between the 12 months for younger patients and 6 months for older patients?
So once you're 35 and over, if you're female, you have a higher risk for an ovarian reserve issue. And so that's something that we want to pick up on right away. We don't want to wait, because diminished ovarian reserve can decline very, very quickly, especially after the age of 35, and then even more so once you hit the late 30s and early 40s. But also, diminished ovarian reserve can significantly impact the success of some of the treatments that we do. And so we want to kind of catch you at a time when your ovarian reserve may just initially be declining in order to get you the very best success rate with treatment. And unfortunately, waiting additional amounts of time can lower your success rate with fertility treatment.
I think that's an excellent way to put it, Dr. Carmon. I also, with my patients, talk a lot about egg quality. And that's something that also we worry about as our patients age. Just like the rest of the human body has wear and tear on it, our eggs accumulate non-reversible age-related damage to it as we get older. And those things can be harder to overcome as we get older.
And Dr. Goulet, can you talk about how many people are affected by fertility issues?
Well, fertility issues are extremely common. Officially, we say about 1 in 8 couples are infertile, but the number of couples that have some component of subfertility is likely much higher because it's not all being reported. Subfertility issues can range the whole gamut of things from weight-related health style choices such as alcohol, smoking, decisions to exercise. And then, of course, there are other health conditions that can contribute to infertility-related issues, such as PCOS or varicocele in men.
I do want to bring up, that kind of distinction that you guys are talking about between subfertility and infertility. Typically, these are used interchangeably. And so when patients sometimes come in and they tell me that they're having trouble conceiving and we do an evaluation for them, oftentimes they're very, very anxious and nervous that I'm going to tell them that they can't have a baby, that I'm sorry, you're infertile. Okay. Technically, you're infertile when you come to my office. Typically, if you've been having trouble conceiving, even if that's subfertility, infertility, those things are used interchangeably. Like Dr. Fraterelli mentioned, it does not mean that you can never have a baby or that if you continue to try that you will not be able to have a baby. And so I can probably count on very few hands the number of times that I've told a patient there is no way that you're going to be able to have a baby without help. And so that is usually those patients who, there's really no sperm in the ejaculate, or patients who've undergone early menopause. And for those patients, actually, there's still some chance for live birth as well. But typically, it's very, very few patients that I say you cannot get pregnant without help.
And I think it's just it's a softer blow to say it's subfertility rather than infertility, because subfertility means that we think you're going to get pregnant. We're just not sure exactly when or how, but we're going to work on it. And I think infertility means you certainly do need help. Your tubes are blocked. There's no sperm, there's no eggs, something that's going on that means that you're going to need some kind of other more. But you can always have a baby. I mean, there's always a way to have a family. There's always a way. We just have to talk about it and figure out what the best way is for you. What about some of the symptoms of infertility, Dr. Carmon?
Well, the main one is not getting pregnant. So that, and again, for 1 year or 6 months, that's really the definition of infertility. And that's actually all you need for that definition. However, there can be other symptoms of some of the causes of infertility, right? So people who have, for example, women who have women who have irregular cycles, women who have a history of some type of surgery, infection, pelvic infection, those kinds of things may lead to tubal disease. Those are all some of the things that may make you want to seek treatment a little bit earlier, on the earlier side. Of course, if you have a known history of endometriosis, known history of polycystic ovary syndrome. And then for men, oftentimes there aren't really a lot of signs for sperm problems, but as Dr. Goulet mentioned before, men who have known history of varicocele or sexual dysfunction may want to see a physician earlier as well.
And on that note, one thing that we're seeing more and more often with men, especially with the prevalence of diagnosis with low T or low testosterone, that treatment can significantly impact a male's ability to get pregnant. And so if you are currently on testosterone, or if your partner has recently used any testosterone for low T, they should also probably seek out evaluation sooner rather than later.
I think that's important, because most people, unless you're a fertility specialist, probably don't realize that taking testosterone is birth control for men, right? it dries up their sperm, so they're not producing any sperm. So and it's, I see couples or men that will come in and they are very surprised when I tell them that. And you can stop the testosterone injections, but it doesn't always reverse the sperm issue, which is a problem, especially if you've been on taking the testosterone injections for a long time. So certainly that would be a concern. And we see more and more people getting those testosterone injections, these days. I see this, I see TTC a lot out there. What is that?
Yeah, so like most people who frequent Instagram, social media, and the internet blogs,
I try.
it can get tiresome to type out all of the long words, so we use a lot of abbreviations. TTC, trying to conceive. That's refers back to what Dr. Carmone was saying earlier, as to, we define infertility starting at 6 months if you're over 35, or 1 year over, or 1 year if you're under the age of 35. So one thing that's important to us is to know how long you have been trying to conceive. Has it been 11 months or has it been 11 years?
And I think what Dr. Carmone was talking about a few minutes ago too is as well, when the symptoms of infertility, if you're having those symptoms, those would be things that you would, again, time is one thing, 6 months or a year. But if you're having other symptoms of infertility, you don't need to wait 6 months or a year. If you're not having menstrual cycles, you're not ovulating. You're not you need to come in right away. If or if you're, having really heavy bleeding, that's lasting for 2 weeks, and, then, those are things that you would need to be seen sooner rather than later, because the chance of you getting pregnant in the 6 month or 1 year mark is going to be very slim. So if you're having other symptoms, you probably should just go ahead and be seen sooner, as soon as you're ready, I guess.
Dr. Farley, I think that's such a great comment, and I want to give a shout out and encourage our patients to be their own advocates, because I know navigating our modern healthcare system can be difficult. And if you're seeing your primary care provider, they may or may not be an expert on what the definition of infertility is, or what your benefits are, and when you should be seen by a specialist. And so if you think that you need to be seen sooner rather than later because you're skipping periods, doesn't make sense for someone to say, oh, give it a year first, and then we'll revisit this topic.
And we're also talking about fertility with a couple, right? So, and a heterosexual couple, but the reality is not everybody has a male and female partner, right? So, if you're a single female or a lesbian couple or a gay couple, you seek treatment whenever you're ready.
Right. So obviously, if you know that you're gonna need help, then there's no reason to wait. Then just go ahead and come in if you know that you're going to require the use of either donor sperm, donor eggs, or the use of gestational carrier.
So I guess, Dr. Carmone, what about, can you kind of talk about, I guess, maybe you can talk about the female problems that would cause infertility, and then maybe Dr. Goulet can talk about the male problems that would cause fertility issues. I think we've hit on a few of them already, but.
Yeah. So I like to kind of look at this in categories. Okay, so when I think about infertility, I want to evaluate the whole system. So first off, we want to evaluate the ovaries and ovulatory function. So conditions like polycystic ovary syndrome or hypothalamic amenorrhea, these are conditions that can cause you to have issues with your ovulation. You may not ovulate regularly, and these conditions are treated a little bit differently, but they're both highly treatable. Diminished ovarian reserve, so ovarian dysfunction due to either aging or kind of premature aging of the ovary, or menopause, right? These kinds of things can cause ovulatory dysfunction and also just diminish the quality of the egg, so that when the sperm fertilizes it, it doesn't really grow properly, and a normal embryo is not really created from that process. And so we can test for things like that with, well, maybe I'll hold off on the testing part, right? So, okay, so that's one category.
That's right.
I know that's Sometimes I talk. Dr. Frederelli has said I talk too much in these, so I'm trying to. I'm really trying to hold back, limit my words. Okay, and the other system obviously is the uterus. So I want to evaluate if the patient has any polyps, fibroid, scar tissue, anything inside the uterus that could cause an embryo to have trouble implanting. The shape of the uterus can also be an issue as well, so we want to take a look at that. The other issues with the female, endometriosis, which can cause infertility. That's something that can really only, we had a whole kind of Facebook Live about that, but that's something that can only really be diagnosed through surgery. But we can have some suspicions if we see endometriomas on the ovaries, or if the patient gives us a suspicious history. Tubal obstructions, so the fallopian tubes, if those are blocked, or if the patient reports a history of pelvic infection or pelvic surgery, then we might suspect that the fallopian tubes are blocked, and we want to look for that. I do want to mention that not everybody with pelvic surgery or pelvic infection has tubal block, and so probably most don't. It's just kind of increasing your risk for that. What am I missing about women? I'm sure I'm missing a lot of other conditions.
I think you covered that very well, and I wanted to add to that part where you were talking about the uterine factor. I think it's society or history. A lot of women sometimes come in feeling scared that they can't carry a pregnancy, that's the reason why they're infertile. Their body is just rejecting a baby, and thus they're going to need a gestational carrier, sometimes called a surrogate. But in truth, that's extremely rare. It's not frequent when we tell a woman you can't carry a baby. Most women's infertility factors are outside of the uterus, most often due to egg number or egg quality.
Right.
And did you talk about egg quality? Did I miss that in your?
I think you missed that. Yeah, egg quality is that's part of the ovulatory ovary part initially. Yeah, egg quality, yes.
Dr. Glay, what about the male? What are some of the issues with the male?
Yeah, so men have it a lot easier when it comes to their workup for assessing infertility. Women will undergo a handful more tests than our male patients do. Our males have to submit to us a semen analysis, and we go from there. And that kind of points us into a direction as to where and how we need to evaluate them. Factors that can cause male infertility include things like a varicocele or a dilated vein in the testicles that can keep the temperature of the testicles warmer than they should be for optimum sperm production. Other frequent causes of male infertility that I see today are that low T and testosterone use that I mentioned earlier. But more and more common, the more frequent causes of male subfertility that I'm seeing are lifestyle choice related or health comorbidity related. So if you've had 10 years of uncontrolled diabetes and you've heard your primary care doctor mentioning that this could affect your health in the long run, it's likely also affecting a man's fertility as well. There are rare other cases or rare other things that we contribute male infertility to, some genetic conditions that might require further workup. Of course, if you've had a prior vasectomy, that would be a reason for concern, but not just vasectomy surgery. We are particularly interested in if a man has had any surgery to their abdomen, pelvis, groin, or testicles, because important structures run in that area that can affect sperm production.
Thank you. I actually muted myself because there's a siren out there. So maybe I'll go over the evaluation process real quick. I think you've touched on a lot of it. Basically, when I sit with if it's a couple, I say, look, we have to look at the main players that are involved with getting the egg and sperm together, right? So for the guy, like you said, it's pretty simple. Usually, they just give us a sperm sample. Sometimes we'll get blood as well, depending on what the thoughts are. And it might be a little bit more involved depending on if they have a medical history. And then with the female, it becomes much more involved because they're not only producing an egg, they have to carry the pregnancy and have the baby. And so we not only want to see what the fertility issues are, we want to make sure that they are going to have a nice, healthy, safe pregnancy and no increased miscarriage risk, right? So we typically will start off with the female, and we try to do it all as much as possible together, so you're not being seen 9 times to get the evaluation done. We normally will say, call us around day 1 of your menstrual cycle. We'll see you as soon as the menstrual cycle is over, which is usually around day 5, and we'll do what we call a saline sternal histogram, where we put a little bit of fluid into the cavity of the uterus to evaluate the cavity, make sure there's nothing in the cavity that would prevent a pregnancy or cause a miscarriage, like a polyp or something. We also at that time look at the muscle of the uterus to make sure there's look for fibroids and make sure that the uterus structure is okay. And then we look at the ovaries very carefully to make sure that the ovaries resemble what they should look like for someone's age. And a 28-year-old ovary looks different than a 38-year-old ovary. We're looking at the number of follicles, and that's helping us with the fertility evaluation at that point. We also get blood work at that point, some basic endocrine labs. We'll get an FSH, an LH, progesterone, a prolactin, a thyroid level, an AMH level, which is probably the most important thing that we get, which is anti-Mullerian hormone level. And we marry that blood work up to what we're seeing with the ultrasound to look at fertility status. And essentially, unlike men, we can't give a cup to a woman and say, give me your eggs. Let me look at them in the microscope and evaluate them. So we have to do an ultrasound and blood work and kind of tease out from there what the fertility status is for the female. And then after that, really the only other test that's needed is the HSG, the hysterosalpingogram, which is usually done a few days later, where a little bit of dye is put through the cervix into the uterus to make sure the tubes are open. That's kind of the most efficient way I can explain the evaluation process. And I don't know if you guys want to add anything to that or not, but that's generally kind of what I'll tell my patients in a nutshell.
You mentioned a lot of anatomic structures there, and I wanted to comment on one in particular because I when I see my new patients, it's a frequent question that I get. You're talking about follicles. What's a follicle? I know ovaries. I know eggs. What's a follicle? And a follicle is the cyst-like structure. Some doctors label them as cysts, some textbooks label them as cysts, but they are the structure that start out microscopically in the ovary, but as the egg grows, it secretes fluid that builds up around the egg, so we can start to see them on the ultrasound. So one of the important pieces of the puzzle for us is to see how many follicles do we see growing in your ovaries, because that can act as a marker for your ovarian reserve.
I also want to point out that a huge percent of infertility is unexplained.
Yes.
And so it is not uncommon that we do all of this workup and then the patients come back and everything looks normal. That doesn't necessarily mean that there's nothing wrong. Well, we know that there's something wrong because the patient's having trouble conceiving, but we're not really finding it. And that's because we are limited in terms of what we can actually find. Subtle egg quality factors may be something that we can't necessarily pick up on exactly because of what Dr. Frederelli mentioned, that we can't actually see those eggs under the microscope unless we're doing in vitro fertilization. So sometimes we're not picking up on that. Embryo development issues, we can't necessarily pick up on that because that's happening inside of a woman's body. We can have some suspicions based on certain markers and blood work, but we can't necessarily say for sure that there's an issues with fertilization. If the sperm looks okay, we can't necessarily see that. And then a lot of people do ask about cervical factor. There are some kind of older tests looking at cervical factor, and potentially there's, I think, some TikTok videos about taking Mucinex to fix cervical factor and things like that, which is not really evidence-based. But there is such a thing as cervical factor, but not really a good way to test for it. There's probably there may be people who would benefit for treatment for cervical factor, but we wouldn't really know how to identify those people because we don't have good testing for it. Okay, so that's sort of the bad news. But the good news is that unexplained infertility is a real diagnosis and has real treatments. And so even if you have some factor that we're not picking up on, I'm just kind of using cervical factor because that's one that we really can't test for properly. Let's say you have a cervical factor and we're not able to test for that and pick up on it. Well, intrauterine insemination is going to be the treatment for that. And so intrauterine insemination is a really good first-line therapy that we would typically utilize for somebody who has unexplained infertility. So we're kind of fixing that problem even if we don't know what it is. So I oftentimes explain this to my patients who get very frustrated when I tell them everything's okay. When I say everything's okay, it doesn't mean that, I'm going to send you back home without a prescription for something, right? It just means that I haven't really been able to find what the problem is.
It's actually a good thing to not find something. I mean, you don't want us to tell you that you have ovarian reserve issue, that there's not enough eggs, or that there's a severe sperm issue or a severe uterine issue. You don't want that. I mean, you'd rather us say, everything looks normal. If everything looks normal, your chance of having conception and getting pregnant is going to be very, very good. You just have to kind of go through the right steps. And I would also add to that, if someone's having unexplained infertility, again, it's a tubal issue too, because we check with the HSG to make sure the tubes are open, but they're not tubes. They're you're not, patency or being open does not mean they're functioning correctly. They're very complex organisms that, or not organisms, but organs that that carry sperm and eggs in the right direction at the right time, and then let that embryo develop in the tube, and then carry it into the uterus at the right time. And if it's not functioning properly, then you either get pregnant in the tube or the sperm and egg don't get together. And so a lot of times it can be a tubal issue, then we're just not able to detect that even though the tube's open. What about, and I guess, there was a question on here about how long do men need to stop smoking for infertility to improve? And it takes about 3 months for sperm to develop. Okay, from the time the sperm develops, matures in the testicle, it goes through all these tubules, which if you lay them out, they're as long as a football field, 100 yards long. But it takes about 3 months for that process before that immature sperm becomes a mature sperm and for ejaculation. And so generally, whatever you do, 3 months later is when you can test to see if it had an effect.
I think you touched on something that I also get a lot of questions about regarding how long is all this testing going to take? How long until we have answers? And typically a workup takes about 1 month. A lot of it is dependent on when a women's cycle begins. And so there may be a pause until we can begin some of the testing until then. But the tests aren't all run in the same day. They do require a couple of visits for us to get all the imaging, all the diagnostics, all the blood work, the semen analysis in before we can review everything together and all the puzzle pieces to see the big picture.
We also have the same question regarding smoking for the female. So how long after stopping smoking does female infertility improve? And so that's more difficult because we're not, as females, we're not making eggs all the time. The traditional way of looking at things is that we're born with a certain number of eggs, and unfortunately those eggs kind of diminish with time until after we're menopausal. But eggs do have cycles as well, and so theoretically that cycle is actually 3 months. It's not 1 month. It's also sort of a full 3 months, interestingly. And so if you're going to make lifestyle changes, then you might see an improvement after 3 months in women as well. But you may not see much improvement or as much improvement as you would see in men who are kind of making sperm all the time. So I certainly urge women to stop smoking because that's only going to help. It's certainly not going to hurt, but we may not see drastic improvements as we would hope.
And on that note, I see a lot of people tell me they stop smoking, they've switched to vaping, or they stop smoking, they're on nicotine patches. And while we are very happy to hear our patients quit cigarette and tobacco use, unfortunately, that nicotine, while it's in the system, still has an effect on fertility. And so completely cutting out all nicotine sources is important for recovering and restoring what some fertility issues that are related to tobacco and nicotine use.
I wonder if you could just kind of briefly talk about the other, habits that people have that might, I'm not going to say unhealthy habits, but habits that people have that might improve, that they can do to change, that they can change to improve their fertility status.
So a big one is actually caffeine. Caffeine can impact.
I knew you were going to start with that one.
Yeah, caffeine can impact both men and women. I have my cup of coffee is almost empty over here, so I don't necessarily practice what I preach whatsoever, but you guys at home should. There are data suggesting that caffeine intake is exceptionally important for miscarriage risk. So the higher your caffeine intake, it does seem like the higher the risk for miscarriage. And there are data suggesting that preconception caffeine intake, so caffeine kind of right around or before the time that you're getting pregnant, may impact your risk for miscarriage as well. And so limiting your caffeine intake to 1 cup a day seems okay. So 1 cup a day or less is okay. There are also data looking at caffeine intake in men and impact on sperm quality and live birth. And we do see an impact when men are drinking more than 2 cups of coffee a day. So is drinking decaf coffee okay? So drinking decaf coffee is okay, but if you drink a lot of decaf coffee, you're going to still have a lot of caffeine. So actually decaf coffee will still contain some caffeine, even typically under 60 milligrams. So you just have to be mindful of how many cups of decaf you're drinking, but yeah, it's okay. And I think people do all kinds of creative things, which are probably fine, drinking half calf, right? And mixing as long as you're cutting back that caffeine intake, which is totaling probably less than a cup of coffee a day, and not just coffee, right? Because caffeine is in all kinds of other things, especially soft drinks, which do have, or Red Bull and things like that. Will have a lot of caffeine in it, so you do have to watch that too. Alcohol intake is also important. Alcohol is, especially for men, alcohol will cause issues with the pituitary axis, so it can actually suppress sperm production, and if you drink very high amounts of alcohol, that's going to very significantly impact sperm production as well. And then for women, there are some data regarding alcohol and inequality and things, but also it's just periconception intake of alcohol is probably not advised, just given the potential impact on fetal brain development as well. What else? I mean, the use of things like illicit drugs, the problem with that is that we don't have a lot of data. There aren't a ton of studies about illicit drug use and equality and things like that. So we usually just kind of use the precautionary principle and say probably avoid those things. Yeah.
So I think one of the things I stole from you, Dr. Carmon, I tell my patients is that if it's bad for your heart, it's probably bad for fertility. Right?
I stole that from someone else, so that's.
Oh, did you? So basically, you try to be healthier than you are. Now there are some people that are just very do everything, and they're ultra healthy, and that's fine. But most people aren't, and so get an exercise routine. If you don't exercise, have a healthier diet. Well-rounded diet. Cut out some red meat. So anything you can do to be healthier probably is going to improve your fertility. But I guess the question is, Dr. Goulet, how much does that help?
It's actually only a small percentage of fertility. If it were easy to overcome, women would drop 5 pounds and suddenly be pregnant, right? As if it were easy to just drop 5 pounds. But on that note,
there are a lot of people out there that are very unhealthy and smoke and drink and do drugs and are getting pregnant very easily. And that's the answer I get from patients.
Right.
And it's true.
but everybody's different, so some women can be 400 pounds and have a whole yard full of children, but some women can be 40 pounds overweight, and that can be a huge factor in preventing them from ovulating normally and having regular cycles. And so while it's easy to sort of preach this idealized lifestyle, medical science has taught us that oftentimes, rather than telling somebody, okay, well, go drop 40 pounds and come back whenever that happens, it's a lot more productive, I think, to turn towards our toolbox of our infertility technologies. Oftentimes, things like that can be treated with affordable oral medications.
I think that I completely agree with that. And it's something that we as fertility doctors often struggle with because we see patients who may be unhealthy, or we think that they may benefit from things like weight loss, for example. But it's really hard because we also have to be practical and realistically, somebody who is overweight, what are the chances that they're going to be able to lose weight in an amount of time where their ovaries aren't going to diminish, or they're not going to become menopausal. So
you have to know that weight is actually causing them to be infertile as well. So I think that's the big issue, is that all of these things aren't going to hurt you. They potentially may help. They may make things easier. They may make you just a little bit fertile, and sometimes it's that little bit that may help. And then potentially, the healthier you are, the healthier the pregnancy is going to be as well, right? So it's really we're helping on both sides. What about the treatments for fertility? I know we've talked about some of them already, but maybe we can talk about some of the treatments for fertility.
Well, I can pick up right where I just mentioned that some of those fertility treatments are the ones that we often start with are called ovulation induction or superovulation. And typically we do this using oral medications that you can pick up at your neighborhood pharmacy. You would take them for a handful of days, starting while you are on your period. And then we would have you come into the doctor's office and we'd evaluate to see how you responded to those medications, typically with transvaginal ultrasound. Sometimes we also throw in some blood work, or more often than not, we also draw blood work at that time so that we can get a hormonal analysis of how you responded to that medication. And if you responded as we hoped you would, we would then add in an insemination to go along with those oral medications to boost pregnancy rates even more. Now, one thing I often tell my patients is that this treatment isn't going to make you superhuman. It's not going to make you super fertile. It will make you more fertile. It'll optimize your peak fertility. But for people who are fearful that they'll get pregnant with, quadruplets from doing one cycle of Clomid, it's not something that happens very frequently.
And so the success rates with insemination sound really low. And so it's kind of, and so sometimes like I'm talking to patients and they're like, that's it, because it's the success rates per try with an oral medication, IUI, let's say on average 10% per try or something like that. Could be lower, could be a little bit higher, but let's say 10% per try. Now, that doesn't sound very good, but that's because human reproduction is not very good. So if you have been trying to conceive for up to 1 year and you haven't been able to get pregnant, even without me knowing anything about you, the literature suggests that your chance for getting pregnant after that year per month is less than 5%. Okay, that's just kind of based on the stats, right? So let's say your chance now without anything is under 5%. If I do an IUI for you, I just doubled your chance to, now it's 10%. So you are doubling your chances for getting pregnant, but human reproduction is just not great. And we've talked about this in other Facebook Live sessions too, but at your peak fertility, your chance for getting pregnant per month, if you're in your 20s and fertile, 25% per month. So that's what we're dealing with here. So we're trying to get you as close as possible to that natural fertility, which is sort of around that 20% mark. And that leads into, the next technology, which is much more successful and exceeds kind of the natural fecundity numbers, which is, of course.
I'm going to have to interrupt you there,
Yes.
Dr. Carmone. That's another word that we don't use very often, fecundity. You want to talk to our
Yes.
listeners out there what fecundity
Fecundity is your natural fertility. Fecundity is your chance for getting pregnant without any help. What is your cumulative chance that you're going to be able to have a baby? That's your natural fertility is your fecundity. So when I say fecundity, like your natural chance for getting pregnant per month, 20% or so, if you don't have any fertility issues, and we're trying to get you close to that. But we can't get you above that with inseminations, really, okay, realistically. But with in vitro fertilization, we can.
And I think that's important to note, because when it comes to setting expectations of how many times do we do this, or how soon will you get pregnant after a treatment, it might take more than one try of oral medication or an insemination. And that's okay, because statistically speaking, we have to give it a fair chance. So 3-4 cycles of oral medications and an insemination is not unreasonable.
So Dr. Fraterelli, do you want to give an overview of IVF?
Yeah, so I guess, I can do that. But I guess when I talk about treatments for patients, I usually say, look, there are only so many ways to get pregnant, right? You got to get the egg and the sperm together. So there's what you've been doing at home, intercourse, hopefully, what you've been doing at home. And then what else can we do? Well, we can give you some medicine to help you ovulate better and have intercourse. Or we can give you some medicine to help you ovulate better, put the sperm into the uterus, that's the IUI. Or we can do IVF. And that's really, there's, again, only so many ways to do it. And obviously after IVF, there's a lot of other things, donor eggs and things like that you can do. But with IVF, what happens is, we will give you injectable medications that will allow more than one follicle to grow. So in a normal menstrual cycle, your brain produces enough hormone, FSH, to cause one follicle to become dominant and ovulate. But you have a cohort of follicles that's there, and you may have 20 when you're in your 20s, you may have 5 when you're in your 40s, but that cohort, one will become dominant and ovulate, the rest of them just die off. We give you extra FSH, a hormone, to rescue that cohort. So whatever you have in that cohort, now we get 6 eggs instead of 1, or 9 eggs, whatever you have in that cohort. And it's basically giving you almost, depending on how old you are and how many eggs we get, we're giving you several months try in one try, ultimately. If we get 12 eggs, that's a year's worth of eggs, a year's worth of ovulating. But then there's extra things that we're doing too. We're making sure that the egg gets the sperm. We're making sure that every mature egg gets a sperm into it, if we're doing ICSI, or if we're just making sure that the sperm is with the egg. And then we're evaluating the embryo and how it divides and how it matures in the lab, and waiting for it to get to the blastocyst stage, which is normally where it would be if it floats from the fallopian tube into the uterus. And at that stage, we will either freeze the embryo and do a frozen transfer, which there was a question about that, or we'll do a fresh transfer. And ultimately, we had done fresh transfers for forever with IVF, and only frozen transfers were done if the fresh transfer didn't work. Until approximately 10 to 15 years ago, we realized that, hey, we're getting better success rates with frozen transfers than we are with fresh. Well, that doesn't make sense, because we're putting the best embryos in first and they're not getting pregnant, and we're freezing these others. And how does freezing make it better? Well, it doesn't. What happens is, during the IVF cycle, hormone levels get really high. The uterus isn't really used to that. And so the uterus may not be as receptive in an IVF cycle for that embryo. It doesn't stay synchronized with that cohort of follicles and that egg and embryo. And so the success rate with a fresh transfer for the majority of people is lower, but not everybody. Sometimes, if you're only making 2 or 3 follicles, your hormone levels are fairly low, then pregnancy rates with the fresh cycle, if everything looks normal, is just as good, if not better, than with the frozen. But if we have to freeze the embryo or embryos, then we have to let you have a menstrual cycle and get the uterus ready. And it takes about 6 weeks to get the uterus ready to do a transfer. So an IVF cycle, if you're going to start from your menstrual cycle, get embryos, freeze them, and then do a frozen transfer, ends up being about 3 months. But that does give you the very best chance of success.
Right. And just to reiterate to all my patients who have done fresh transfers out there, okay, we many
No, but I did say that there are some that, and we only do fresh transfers if everything's
you're
perfect.
just a
Right?
little,
Yeah.
so just a little too kind of gung ho about the FET. No, I think for the majority of patients, frozen embryo transfer will benefit, but for patients whose hormone levels remain low because we're doing a natural cycle or because they have a lower, issue with their ovarian reserve, they're not producing a lot of follicles, and they may benefit from fresh transfers.
That's a good point, because we have patients come to us all the time. It's completely not, I'm not talking about what you just said. It's completely off topic, but we have patients come to us all the time that read something on Google, or they talk to their friend. My friend did this. My friend did that. The reality is, what you have to do is when we're talking, when I say a frozen transfer is the best thing to do, it's not the best thing to do for everybody. It's the best thing to do for a lot of people, but everything is individualized for everybody. And so if it's not the best thing for you, then that's not what you need. And that's what your fertility doc or your provider is going to assess for you.
There are also a lot of other treatments that I think we're not going to necessarily get into detail about. Surprisingly, there's a ton of stuff, and there's also not a lot of things. And I always feel like I'm talking to patients. I'm like, well, you could do IUI or IVF. Like, which one do you want to do? And so sometimes it's kind of like they're like, that's it. Anything else? I'm like, no.
Well, yeah, I get a lot of questions
right.
on, you've told me my tubes are blocked. Can't you unblock them? Can't we do
Right.
surgery? And unfortunately, those surgeries don't work very well. They just scar right back over.
We're always like, why would we do that when these other things work so well? So that's kind of the good and the bad thing. But then within the category, and that's why we have to do all this training and get board certified, I suppose. I don't know, but it's because of the fact that within these categories, there's all kinds of nuances and things and technologies that we have to understand and be able to utilize. So there's in vitro fertilization that Dr. Fraterelli gave you this overview on, but then there's also the utilization of donor eggs, and we can probably have a whole Facebook Live just talking about the different types of donor egg cycles, and we should definitely do that sometime. There's also other ways to manage IVF cycles. So there's a possibility for natural cycle IVF, mini IVF, InvoCell, which is a vaginal incubator. And so that can sometimes cut the cost of IVF a little bit, but also offer some options for people who want to do things more natural way, or some people for religious reasons, if they want fertilization to occur inside the body.
And I'll stop you there just for a second, because I know that on May 26th, that's going to be our next, and we only have a few minutes left. On May 26th, that's going to be our next Facebook Live session that we're going to do live stream, and we're going to talk about IVF. And so we'll have a lot of time to talk about IVF, because there's a lot of different things that you individualize the cycle for everybody, and there's a lot of different things that you can do. But then there's a lot of things behind the scene that are happening with embryology, and it really is very fascinating. We could really talk about just embryology, and that would be very fascinating, I think. But at least I would find it fascinating. I'm not sure everyone would, but it's just, it's amazing what not necessarily what we do, but we as a facility, can do, and the embryologists are just amazing, with their skills. So again, I think it's I love what I do because of the novelty of the field, and things are changing so much, and it's just nice to help people have families. Unfortunately, we're not always successful, but we definitely do always try our best, I think. There's a question about before we end. There's a question about COVID vaccine. Either one of you want to tackle that, and conception and pregnancy?
Did you see that there's a new CDC actually recommendations that the vaccine is endorsed by the CDC during pregnancy? And I know that was a long time coming, a long time waiting for us to hear that. We've always had this stance where we, as in the American College of Obstetricians and Gynecologists, the CDC, the American Society of Reproductive Medicine, has said it's safe to get the COVID vaccine while you are pursuing pregnancy. So while you're in fertility treatment or while you're trying at home, absolutely, if COVID vaccine is offered to you, then that is definitely something that you can take, knowing that it's not going to harm your fertility. As far as getting the COVID vaccine in pregnancy, we have very limited data on that. A lot of the data that we have for pregnancy was not done during the randomized trials, but was self-reported on women who voluntarily chose to get the vaccine during pregnancy. And now the CDC has said that they've got enough of that data where they've seen no major adverse outcomes to the pregnancies that they feel safe endorsing the vaccine during pregnancy.
Any other comments from either one of you, or things you want to add?
I think we can definitely wrap up. It's been kind of a long session. I think next time we'll talk about in vitro fertilization and really go into detail about protocols, some embryology stuff, and yeah, stay tuned. Meet us there.
Yes, we'll see everybody on May 26th.
Okay.
Have a wonderful
Aloha.
afternoon.